Hello, my name is Deidre Larrier, and I'm one of the otolaryngology faculty in the Bobby Alford Department of Otolaryngology through Baylor College of Medicine. And today we're going to talk a little bit about pediatric sinusitis and its complications. First, let's start with today's objectives. We're going to look at the anatomy of sinuses, the pathophysiology of sinus disease, treatment, and complications of said sinus disease, especially as they pertain to the pediatric population. First, let's look together at sinus anatomy, and here we have two pictorials. On the left side, you can see that the frontal sinuses live above the eyes or orbit. Between the eyes or orbit are the ethmoid sinuses, and you can see on this pictorial that these have a honeycomb format. And right in our cheeks lie the maxillary sinuses. Other important pieces of anatomy are our midline septum of our nose, as well as the turbinates that lie, three of them in each nasal cavity: the superior, the middle, and the inferior turbinate. The coronal CAT scan shown here is again a very good depiction of these sinuses. You can see slivers of those frontal sinuses. The E here represents the ethmoid sinuses, which are just medial, just inside of the eye or orbit, and these maxillary sinuses are represented here. Remember, black means air, and that is good. The turbinates that we pointed out on the last slide are here again is the middle turbinate on this side and the inferior turbinate on that right side. The U with the asterisk here represents a very special area. U stands for uncinate process, and it lies right in what we call the middle meatus, the area housed by the middle turbinate. And that area is very important because the three adult sinuses shown here, frontal, ethmoid, and maxillary sinuses, all drain into this port. So far, we have talked about three of the four sinuses, and we haven't spoken about the sphenoid sinuses as yet. Let's take a look on these axials and see if we can find the sphenoid sinuses. We'll begin up high, and here you see the frontal sinuses on this left-sided CAT scan. Moving right along, you see the ethmoids. So one cut down, you're looking at the ethmoids between the orbits. And if you go straight back posteriorly, now you see the sphenoid sinuses. These actually drain independently into the back of the nose. If you keep going down, you will then again see the maxillary sinuses. This is the right-sided maxillary sinus and the left-sided maxillary sinus. And this cut is also good for demonstrating that when there is disease, there is graying of the sinus, whereas when the sinus is healthy and disease-free, there's a black color, which means it's full of air. Here we're going to take a tour through the nose, and this video is compliments of Dr. Mas Takashima, who is head of the Sinus Center at Baylor College of Medicine. Here we're going straight back through the left nostril, ducking under the inferior turbinate and heading straight back to the posterior nasopharynx. Here's the eustachian tube orifice. Here's a look at the adenoid tissue bed. And coming right back out, we're able to angle upward and see our middle turbinate. Just inside that would be the middle meatus that we talked about, and your uncinate process is right here. As we head back one more time, we will soon be able to angle superiorly, and you'll be able to see the sphenoid sinus ostium. This is a very good view and very hard to see in many noses of where the sphenoid sinus drains into the back of the nose. Moving on to our next slide. Let's take a look at the embryology of sinus formation. This slide reminds us that at birth, only the maxillary and the ethmoid sinuses are formed. The sphenoid sinuses form next between the age of 2 and 5 years, and the frontal sinus forms later between the age of 7 and 8 years. And remember that these continue to develop into adolescence. This brings us to our first question on sinus anatomy. How many kinds of paranasal sinuses does the human adult have? If you guessed 4, you are correct. These are the frontal sinus, the ethmoid sinus, the maxillary sinus, and the sphenoid sinus. We'll move on next to the pathophysiology of sinus disease, and as shown here, X marks the spot. Remember, the area just inside of the middle turbinate is called the osteomeatal complex, and it is obstruction at this point that we think triggers sinus disease. If there is obstruction at the osteomeatal complex, there is stasis of secretions within the sinus themselves. This leads to bacterial overgrowth inside the sinus. An immune response is triggered. There's tissue congestion that results, and this in turn further worsens the osteomeatal complex obstruction, and you can see how we end up in a vicious cycle. We think that younger children are at increased risk because of the following factors. They're smaller anatomic structures. They have more frequent viral infections, perhaps related to daycare contact. Increased exposure to indoor allergens and irritants just because of their habits, and perhaps an immature immune system. Here's a question on pathophysiology. What key region is blocked during sinus disease? If you guessed the osteomeatal complex, you are correct. Let's move on now to the microbiology of disease. Acute rhinosinusitis is known to be caused most of the time by 3 main pathogens. These are strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis, a very important question for exams. In the clinical practice guidelines established for pediatric acute rhinosinusitis in 2001, 2 definitions are key to understanding the algorithm that follows. For persistent symptoms, these are symptoms that last longer than 10 to 14 days, which is quite long in today's society, and they're accompanied by postnasal drainage and cough. For severe symptoms, patients should have a temperature above 102 degrees Fahrenheit and very purulent nasal drainage which lasts for at least 3 to 4 consecutive days in a child who also seems ill. This slide is quite busy, but remember you can pause and follow, and I'm going to guide you through the key points shown here. In this slide, when you're managing children with uncomplicated acute bacterial sinusitis, and their disease is mild to moderate, the child is not in daycare, and the child has not been on recent antimicrobial management and is not allergic to penicillin, your first line of management is with high-dose amoxicillin. Note that in the box in the upper right-hand corner, definitions and doses of medications are given. So high-dose amoxicillin, for example, is 90 milligrams per kilograms per day in 2 divided doses. If the child is in daycare, or if the child has had a recent antimicrobial treatment, or if symptoms seem severe, we would move on to either augmentin or the cephalosporin shown here. If a child is allergic to penicillin, here are some other options, including zithromax and clarithromycin, also known as Biaxin. And finally, if a child is refractory to these antibiotics, intravenous therapy may be needed. Note that if these things fail, sinus imaging with CAT scans like you've seen recently, or even sinus aspiration involving otolaryngologist will become necessary. Nasal saline, nasal saline, nasal saline. Here is a chart of options of the ways you can use nasal saline. Some people use washes, which is the most thorough kind, but then there are also sprays that you can use really to dissolve and cleanse the mucus from the nose. Here's an example of a girl at the age of 4 who is rinsing with nasal saline in what we call a neti pot format. The other key nasal management is using nasal steroids, and this is just an example of one that's approved for children down to the age of 2. This is Nasonex, and this is administered as one spray daily for at least 4 to 6 weeks for maximum benefit. So, in the treatment of sinusitis, what is first-line antimicrobial therapy when acute sinusitis is suspected? If you said high dose amoxicillin, 90 milligrams per kilogram per day in 2 divided doses for extra credit, you were correct. What are the 3 most common pathogens that are responsible for acute sinusitis? These are strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Next, we're going to move on to the complications of sinusitis, and we'll start with the most common kind, which are those that affect the orbit or the eye. These are known as Chandler's classification, and this is very important to know on your ward rounds and in real-life patient care. There are 5 elements in Chandler's classification. They're not meant to go in order of severity, but note that cavernous sinus thrombosis does deserve special mention. In this special case, there can be bilateral disease with severe headache, photophobia, and even decrease in visual acuity, which can end in blindness. There is also the possibility of palsy of cranial nerves 3, 4, 5, and 6. The more common kinds are the preseptal cellulitis, orbital cellulitis, subperiosteal abscess, and orbital abscess, and we'll take a look at some photographs of these shortly. In orbital cellulitis, and really in all of the categories, even though the disease begins in the sinus itself, there is a breach of the lamina papyracea, the thin bone between sinus and orbit. And when this happens, disease enters into the orbital space. On this CAT scan, which is an axial cut through the orbital region, you can see that there is haziness or disease which has entered the orbit itself on the right side. It is causing inflammation of the medial rectus muscle, and it is causing the orbit itself to be pushed out, which is called proptosis. On this coronal CT on the right, you can again see the moth-eaten appearance of that lamina papyracea, which is allowing disease to spread into the orbit. In subperiosteal abscess, in addition to the extravasation of disease into the orbit, there is a walled-off abscess that forms. So here you see the periosteum of this bone, which normally would lie flush on the bone, is being pushed out and housing an abscess. And this is called a subperiosteal abscess. This requires surgical drainage. Most commonly nowadays, it's done endoscopically through the nose and with removal of disease from the ethmoid sinuses and drainage of that abscess into the nose. On the right-hand side, again, you can see that walled-off abscess just inside the lamina papyracea area. Complications of sinusitis can also come in intracranial or pulmonary areas. In the intracranial section, there can be meningitis, epi or subdural abscesses, and cerebral abscesses. Pulmonary complications can be in the form of bronchitis, asthma, and cystic fibrosis. This is an example of a frontal brain abscess, and of course, I'm sure you have no problem seeing that. This sagittal cut on the right does remind us that the disease is likely coming from the frontal sinus, which is full of fluid here and has likely breached the bony barrier and entered the brain. Similarly, on this sagittal CAT scan, you can see a walled-off abscess in the frontal region, and the key that tells us this likely came from the frontal sinus is the air that's tracking into the brain. This slide also reminds us that in the same patient, if we use contrast CT, we have much better definition of disease than if we use a non-contrast CT where this frontal abscess could easily have been missed. So here's our quiz question on complications of sinusitis. Can you name at least 2 elements of the Chandler classification? Of course, there are 5 elements, and so if you chose any 2 of the following, you are correct. In summary, In today's presentation, we learned that in the human body there are four paranasal sinuses: the frontal, the ethmoid, the maxillary, and the sphenoid sinuses. Sinus disease is triggered by obstruction at the osteomeatal complex. First-line treatment is with high-dose amoxicillin, and complications of sinusitis can affect the orbit, which is known as Chandler's classification, and also the brain and the lungs. Again, my name is Deidre Larrier, and I'm one of the pediatric otolaryngology faculty through Baylor College of Medicine. And I invite you to email me with any questions you have on today's presentation. Thank you for your attention.